and we actually have a skit, and we have 4 volunteers who are going to do our skit for us while they're getting themselves organized. So it's Arnie Gorski, who spoke this morning, and Joel, who works with us, and Sandy and Katie. If y'all just want to come up over to the side here, and then in a minute we'll go up on the stage. While they're getting themselves organized, I'm going to open us in prayer so that we can keep our energy up for the rest of the afternoon. So, God, thank you so much for this day of learning and networking and seeing the needs and the resources. Help us each to process this and to follow what you are saying to us this day. In Jesus' name I pray, amen. Okay, so we are going to discuss WHO. So again, this is a learning and resource session, so it's some case studies in tropical medicine, but the focus is more on the process and the principles and the resources that you can use when you see tropical diseases. So we want to discuss WHO and evidence-based guidelines and standards as they relate to treating the most common tropical diseases. And I think we're missing 1 or 2 of our actors. So let's see. We have all 3 of you. Okay, so we have one little child, one little child, a pig, and an adult. And y'all can come up here. Thank you so much. Yeah, up here. Be careful on the stairs. You're just acting it out. Yeah. Good job, actors! Woo! Thank you, guys. Okay, so what was happening in that skit? What did you see? Someone went to the bathroom, somebody, the dog or something. It's transmission. Yes. So someone went to the bathroom. It was actually a pig that then ate it, and then it was several months to years later that the person who ate the pig had seizures. Okay. So this is the town in Peru where this occurred. And you can see the pig's head in the market and the dog. This is laundry day and also gut cleaning out of the pig day. So now the 48-year-old man, she transformed very quickly, who had the seizure, came to your hospital. And his family reports he has had 2 similar episodes over the past 3 months. He has not been ill recently. He does not have a fever. On exam, you notice some non-tender, non-mobile lumps under his skin. So what would the chief complaint in this scenario be? Seizure. And what would your differential diagnosis be? Oh, you guys are all too smart. Okay, so what would be other differentials that you would consider? Toxin exposure? Post-traumatic, drugs or toxins, some kind of encephalitis. Awesome. CVA? Mm-hmm. So especially in the US, but in globally around the world, non-communicable diseases are increasing, so CVA. Anything else? Meningitis or encephalitis. Yeah, meningitis, encephalitis, any type of space-occupying lesion is another one. And malaria can also cause some meningitis. Now, he didn't have a fever, but these are all excellent work, group. So it is neurocysticercosis. So who said that, and how did you know that that's what it was? Well, you have a pig. Yes. Right. So neurocysticercosis is actually a type of pork tapeworm. It's caused by a type of pork tapeworm, so it's transmitted through pigs. Now, what the actual full cycle of it is that if a pig eats the eggs in soil or poop or whatever, the pig develops the cysts throughout its body. And if a person eats the uncooked or undercooked pig, then the person maybe 6 to 8 weeks later might have some digestion upset or might really have no symptoms at all. But then the person can reinfect themselves or their family with the eggs and develop cysts within their own body. And the cysts can be in the muscles, the skin, the central nervous system. So the nodules under the skin doesn't happen all the time, but that's a clue. But this one was having cysts in the brain from the pork tapeworm. So the symptoms, you can have these cysts and be asymptomatic, or you could have headaches, blindness, seizures, hydrocephalus, dementia. It really depends on the number, size, location of the cysts, and the host immune response, which is a key to hang on to for the treatment. It's an inflammatory reaction to the living and dying parasites. So we can have long-term fibrosis, calcification, and granulation. And diagnosis is through CT, MRI, or serology. How many have worked in Africa or Latin America? How many have had CT, MRI, or serology in Africa or Latin America? Okay, so WHO says an improved, simple, cost-effective, and rapid diagnostic tools are still needed for use in field conditions. WHO and partners are addressing the lack of a suitable diagnostic toolbox by developing standards for diagnostic products tailored to the needs in countries and especially field settings. So they're basically saying it's a field diagnosis, a clinical diagnosis at this point, but they are working on it to see better diagnostic methods. So the treatment, if you're having someone having seizures, obviously is anticonvulsant treatment. If they're not having seizures, they wouldn't need it. And then antihelminthic, because it's a tapeworm, so we're gonna do some deworming treatment, but this is long courses, like weeks to months of your albendazole, mebendazole, ivermectin, and it will not work on those dead calcified cysts. So you may have some permanent damage that if it's causing seizures, they will need anticonvulsants the rest of their life because you're not going to get rid of those cysts. And here's the key. Use steroids while you're giving the antihelminthic treatment because you're creating more of an inflammatory reaction that's going to create more space-occupying lesions in your central nervous system and your brain. And if it's a space-occupying lesion that's causing problems like hydrocephalus, it may need surgery. So why are we even looking at this? Neurocysticercosis is the most frequent preventable cause of epilepsy in the developing world. It causes 30% of epilepsy, and it was named by WHO as the foodborne parasite of greatest global concern. Now, we have a select group here because you all are quite experienced working internationally, but before you started working internationally, when you worked in the United States, have you ever heard of neurocysticercosis? It causes 30% of epilepsy around the world in endemic cases and the most frequent preventable cause. So and you can see the map here, the red is where it's endemic, and then the lighter colors, as it gets lighter, you have less cases of it, which is also why we don't learn that much about it because we live in the white area. But it's called a neglected tropical disease because most people and most trained physicians, if you think of the around the world, the healthcare providers, numbers of healthcare providers, haven't really heard of it, and it's been kind of neglected. So neglected tropical diseases listed by WHO, NIH, CDC, USAID, grant programs like the Gates Foundation look at these neglected tropical diseases as a subset to focus on because they affect more than 1 billion people in 149 countries around the world. And we haven't really been doing much about them so far. So this is from the WHO website, the current list of neglected tropical diseases that are on there. This is then when you actually click on the toniasis one, it takes you to cysticercosis and neurocysticercosis and a whole page, several pages of information on that. Again, these are your resources. And then WHO also has, so when I go to WHO, it helps to know the keywords to type into the search box. So for instance, I know to type in neglected tropical diseases and I'll get to these pages. And if I just type in tropical diseases, I'll get to this page, which goes into some other tropical diseases that may not be called neglected. So most of the information that I use is from WHO, CDC, and then the Oxford Handbook of Tropical Medicine are my main sources. So I'm a family doctor, not quite the cut 'em and be done surgeon, but also not quite the academician. So I went, what are my practical, easy handbooks that I can use and not have to go through the entire pathophysiology of things over and over again. So in our skit was actually from a CHE lesson, a community health evangelism lesson. I don't know if Terry's back in the room or not, but that is a skit that's used in a lesson that's used with community health workers or community members, not even medical professionals. And throughout the lesson, it goes through what is the series of steps that we saw, what do you think caused the man's seizures, what leads to tapeworm infections, why are pork tapeworm infections dangerous, how can they affect the affected person and their community and family, and is there something better than treatment since treatment is costly and long and difficult? And then what can we do to prevent pork tapeworm? So those lessons are another resource if you get into community health evangelism that can be adapted to multiple levels. So that was a lesson written for a community or a community health worker, which I have adapted for you all as healthcare professionals. So there can be multiple levels. And when you're looking at prevention in the community, you can have them, even draw out the series and mark X's where they could prevent, like don't eat the undercooked meat, don't contaminate things with feces. So, okay, moving on to case number 2. Great job. So this is another source that we use at Christian Health Service Corps. As Greg said, we have training programs throughout the year. Usually in June, we have a global health and tropical medicine course that's 6 days in length that goes through case studies like this, and then global health guidelines like the WHO guidelines like IMCI, which we'll get to. So we have this book at our booth downstairs. It's called the Village Medical Manual. And there's a new edition, and we like it because it goes through, there's 150 case studies of tropical diseases around the world or of diseases in the developing world or the majority world that we can go through as healthcare professionals. I'm going to read this. As I read it, I want you to mark down or make note in your head of pertinent positives and pertinent negatives for our discussion that will follow. So this is Ermias Buff. He is a 2-year-old Ugandan male whose mother brings him to you with the chief complaint of fever for the past 6 days and a rash since 3 days ago. She reports that many children in her village have had a similar illness and some of them have died. Ermias began to have a runny nose without a fever about a week ago. Then he developed a fever, sore eyes, and a cough. He refused to eat. The day before yesterday, the rash broke out and he appeared to be sicker than before. He has vomited once and had diarrhea twice. Past medical and social history, Ermias is the second youngest of 6 children. He has a newborn sister. His parents are subsistence farmers who supplement their income with doing crafts for the tourist trade. He has never been sick before. He has had no immunizations, is on no medications except for ORS, because his mother knows to make that, and has no allergies. On exam, he is alert, he appears well-nourished, but currently ill. His temp is 102.6, pulse 140, respiratory rate 30. Weight is 10 kilograms. His entire body is covered with the rash. If you can see it on his face here, it's covering his entire body. Head is normal size and shape. Pupils are fine, corneas are clear. The whites of the eyes are bloodshot. Inside the lower lids is quite red. The nose is normal shape and without sores. The outer ears, canals, and eardrums are normal. He has 18 baby teeth. The mouth is dry on top of the tongue, but most underneath. There are some red spots in his mouth. The tonsils are normal size and color. There are a few enlarged lymph nodes on the neck in the front. The thyroid is not enlarged. He can move his neck in all directions. Heart sounds have no murmur. Lungs are clear. Bowel sounds are present and normal. Liver and spleen are not enlarged. Abdomen is soft and non-tender. There are no enlarged lymph nodes in the groin. The kidney area in back is not tender. Arms and legs show no swelling. The patient can move his limbs in all directions without complaint of pain. So there's our case. We're going to talk about the pertinent positives and negatives in a minute. In the Village Medical Manual system, she gives us options. Wait and see how he does. Give his mother some medicine to use, enough for 7 to 10 days. And what medicine would you give him? Give his mother enough medicine for 1 day and have her check back, or send him and his mother to a local clinic, which would cost $22, or to a private hospital, which would cost $150. So we're going to go through this case using the IMCI system, but, I'm showing you. So what were some of your pertinent positives and negatives that you picked out? Fever, rash, lymph nodes, runny nose, Koplik spots, okay. Oh, that he has 5 brothers and sisters. Yes, okay. And there are other ill children? No immunizations? And other children have died from this. Good. What did I hear over here? He doesn't want to eat? Okay. Okay, so fever, rash, runny nose, sore eyes, cough, vomited once, diarrhea once, no immunizations, good job picking that up. Fever, the temp 102.6, his eye exam, red spots in his mouth, which we heard were called Koplik spots, enlarged lymph nodes, and then his tonsils, his eardrums, his tonsils are normal. These are my negatives. He can move his neck in all directions, his lungs are clear, the liver and spleen aren't enlarged. So again, we're working on process and resources, right? So from our pertinent positives and negatives, we make a problem list. If you've ever, sometimes in medical school, we would make a problem list. So this is the problem list that are just listing out those pertinent positives that we listed out before, that we listed out previously. So, is there a resource that can help us address all of these issues on his problem list? Have we mentioned a resource throughout the day? And if you were in this room in the hour before us? But the body will heal itself over time, yeah. Although people are dying, so we might want to do some intervention. What did I hear over here? IMCI. So I wanted to use this case to help us go through the Integrated Management of Childhood Illness, which was designed by World Health Organization for under 5-year-old children, realizing that high morbidity and mortality is in under 5-year-old children. And it's an integrated approach. So we, in our Western-trained mindset as healthcare professionals, pretty much immediately jump to a diagnosis. However, there are several issues on the problem list that may or may not be associated with that diagnosis and that we still need to address to treat him. So IMCI helps us, if we don't have as much education or the people that we're working with, even community health, to look at syndromes and treat the symptoms and the issues that are most likely to kill the children. And from 1990 to 2018, so IMCI was started in the 1990s. From 1990 to 2018, the global under 5 mortality rate declined by 59%. So this is our encouragement. There are other things going on besides IMCI, but since IMCI started until now, the global under 5 mortality rate decreased by 59%. There were 93 deaths per 1,000 live births in 1990, and now there are 39 per 1,000 globally. However, there's still a disparity. The highest under 5 mortality rate is still in the WHO Africa region, which is at 76 per 1,000 live births, which is 8 times higher than the European region at 9 deaths per 1,000 births. And in 2018, 5.3 million children under 5 still died. So this is really encouraging that we have something that's helping and that's working, and we should continue using it so that we can continue decreasing that. So we used to have millennial development goals. Everybody remember millennial development goals? Well, we're now in the millennium, so we have sustainable development goals. And the sustainable development goal number 3.2 is to reduce under 5 mortality to as low as 25 per 1,000 live births in every country by the year 2030. And how much are we at in Africa right now, the African region? 76. So We have a ways to go, but we have tools to do it. This is what you can download the IMCI chart booklet, this chart booklet from the WHO website. Again, my keywords, I just do integrated management of childhood illness, and it gets me to this booklet that I can download that goes through things. So this is kind of the table of contents of the booklet. But it's the process that they go through. Assess and classify the child. The first assessment is, are there danger signs that we need to address immediately? And if not, then assess and classify. And then treat the child, and then follow up and counsel and educate. So again, putting the affected person and or their family involved in the process. And again, IMCI is looking at the top causes of childhood morbidity and mortality. So this graph is from 2016, and about half of under 5 deaths are in the neonatal period, which is 0 to 27 days. We're not going to focus so much on that. That is through the integrated management of pregnancy and childbirth and care of neonates. There are some other programs there, but there are things that we can control during pregnancy, like prematurity, can or can't control prematurity, neonatal tetanus. There are neonatal sepsis, things that we can't really control, like congenital anomalies, so those things. But if you look at the postnatal period, the leading causes of death have remained with varying degrees of changing their position in the top 5: pneumonia, malaria, measles, diarrhea. And malnutrition kind of is an underlying contributing factor to all of those. So those are our causes of death, and that's what IMCI looks at to say, this is what's causing the deaths, how can we decrease mortality? So this was our problem list. Again, for Amias Bruff, we're going to go through his case using IMCI. So the first thing we do is check for general danger signs, which are if the child is able to eat, if he's not able to drink or breastfeed or eat anything, does he vomit everything, has he had seizures? If he's lethargic or unconscious, and is he convulsing now? Those are all things that we would say we need to quickly assess everything else and get him to a center for treatment if we're at the community level. And then it even over on the right-hand side is saying he has a danger sign, he has very severe disease, give diazepam if convulsing now, quickly complete assessment, pre-treat and refer, and how to do that. And there are pages in the back that give all of that Greg went through an hour before this, if you were in here, that give the doses and everything. So he didn't have any general danger signs. So the next step that we'll go through in the IMCI booklet is to ask about respiratory symptoms, because pneumonia is part of the causes of death, right? So he didn't have any stridor, chest indrawing, or fast breathing. So he actually fits into the green category, no signs of pneumonia or severe disease. Again, this is to quickly go through an overview that you can look through on your own later. So he's green, maybe cough or cold, but not severe pneumonia disease. So we can move on to, does he have any diarrhea? Now, diarrhea is in the chart, bloody or non-bloody, and under 14 days or over 14 days. So his diarrhea was non-bloody, less than 14 days, and he didn't have any of the danger signs of dehydration, which are listed there. So we would give him ORS, which his mom was already doing, zinc supplements, which Greg talked about, and if you were not here, it will be in this IMCI booklet. It decreases the length and recurrence of diarrhea if we give zinc supplements during a diarrheal episode. Okay, the next one is, does he have fever? And we're going to look at this page in 2 parts. So the first part of fever is if you are in a zone that has malaria, or if you are in a zone that doesn't have malaria. So if you're in a zone that has malaria and you have rapid diagnostic tests, according to WHO IMCI, you would perform your rapid diagnostic test and treat accordingly. If you don't have rapid diagnostic tests, but you're in a zone with malaria, you would treat for malaria if a child has a fever, a child under 5. And if you're not in a malaria zone, you look at some other risk factor or some other danger signs and warning signs. And here's where we all jump to begin with. So has he had measles or been exposed to measles, and currently does he have something that looks like measles? And the WHO clinical case definition of measles is fever and rash and cough, coryza, or conjunctivitis. So there's our 3 C's: cough, coryza, which is also congestion, cough, congestion, conjunctivitis. So this is how our trained minds jumped to this. But going through the process really helps us not to miss any of those other things and to work alongside. So I learned IMCI when I was directing a hospital in Nigeria. My family medicine residents taught me IMCI. I was supposed to be teaching them. Because in a lot of the majority world, this is how people are taught and what they're learning. And if we go there and say, well, our way is better or we have a different way, that's not really coming alongside and helping all of us to move along together. But if we say, oh, we're familiar with this IMCI, tell me more about it, how do we use it? That then can help us to continue moving along and decreasing that morbidity and mortality. So after we correctly diagnose that he has measles and have addressed anything, the fever and the measles, then we would check for malnutrition and check for anemia and check for HIV. And there are actually, the IMCI booklet has a section on malnutrition, but there are other supplemental booklets that talk about hospital malnutrition versus community-based malnutrition treatment that are all in the WHO website. And for every child that we see, unless they have one of those danger signs that says assess and refer quickly, once they're stabilized and we're treating them and they're getting better, or if they don't have a danger sign, we still check their immunization, vitamin A, and deworming status. And vitamin A supplementation for 6 to 12 months is 100,000 units, and for over 12 months is 200,000 units. So we don't give vitamin A in the United States, but we have found that regular vitamin A supplementation in countries that are mostly in that majority world that are low in vitamin A helps with morbidity and mortality, and it's right along in their immunization schedule. Give them vitamin A and then give them deworming medication, and which is mebendazole 500 milligrams once. And all of that, again, I would encourage you to look at the actual treatment protocols for. But those are things that we're like, what? You're giving deworming medicine every 6 months? You're giving vitamin A? What's going on with that? Also, let me make sure. So for measles, part of the management of measles is extra vitamin A supplementation. And there are theories, but no real known facts about how it works. But we know that giving extra vitamin A and higher doses of vitamin A to kids with measles helps them to recover better. So for our Ermias buff, we're going to treat malaria if there's no test available, or he tests positive because he lives in Ethiopia, which is in the high-risk zone. We're going to give him vitamin A and watch for complications and manage malnutrition. Did I skip over? So who all knows what are some of the complications of measles? Encephalitis? Pneumonia, right? Encephalitis, pneumonia, death. I'm actually missing some slides in here. Sorry, guys. Oh, no, I'm not. Okay, I'll get to those slides in a minute. Okay, so these are more specific guidelines on management of severe acute malnutrition in infants and children, so like the hospital management and then hospital care for children. So IMCI is a community outpatient-based assess, refer if needed, handle what you can at your location, and then WHO has more booklets for us to use in other settings. This is the healthservicecorps.org website, Christian Health Service Corps website, where we actually have links to the online training for the IMCI as well as integrated management of pregnancy and childbirth. Okay, so measles is a highly contagious virus that's transmitted through direct contact and respiratory droplets. It remains active for up to 2 hours. And the infected person is contagious 4 days prior to when their rash erupts until 4 days after their rash erupts. Up to 9 out of 10 susceptible people with a close contact to a measles patient will develop measles. So one of my other questions when I started looking into all of this was, why are we so focused on measles? Well, it's really contagious, and it has the sequela or the complications that we talked about. So we talked about cough, coryza, conjunctivitis. Koplik spots are actually white spots in the mouth, and this is depicting, it's not a great picture, but it's from the CDC trying to depict the Koplik spots. And we talked about the complications, and then death, right? Death is a complication of almost anything. But in developing communities, so in the majority world, in the areas where we're working, there's a 3 to 6% death rate from measles. If we go back to my talk this morning on displaced groups, there's a 30% case fatality rate for measles in displaced groups like refugees because they're living in close quarters. So supportive care, hydration, nutrition, antibiotics for any concomitant infections, and the vitamin A doses are here. If there's signs of vitamin A deficiency, you would give a third dose 4 to 6 weeks later, and vitamin A reduces the number of deaths by 50%. Another encouragement, so WHO has a global vaccine plan for measles and rubella, and between 2000 and 2018, there was a 73% decrease in measles deaths that was attributed to this global vaccine action plan. So this was actually studied and attributed to. That was 20.4 million deaths that were prevented with this global vaccine action plan. But in 2018, 140,000 children still died of measles. So we just talked about 3 to 6% case fatality rate in general in the developing world, but a 30% case fatality rate in a refugee settlement. So how would the case change, or what would you do differently in a refugee settlement? Any ideas? You would use the Sphere Handbook, which under child health standards, so now this is one of those sections of health standards, there's a child health standard, there's childhood vaccine preventable diseases, and you would conduct a mass vaccination campaign if the measles immunization is less than 90%. If the immunization rate in your camp or in your community is less than 90%, you would, or unknown, which is the more likely thing, you would conduct a mass vaccine campaign. And it says measles immunization is a priority health intervention because of that high contagiousness and the high mortality for it. Okay, we all hanging in there? This is case number 3 of 3. This is also a pretty simple one, but again, it's to point out our resources. So this is Elmer. He's a 12-year-old little guy I saw in Honduras several years ago. He was out tending cows. When he didn't come home at the time that he usually came home, his brother went out looking for him and found him lying in the field in a fetal position. So he presented to the mission hospital with 8 hours of worsening abdominal pain that started centrally and radiated to the right lower quadrant, and he had some vomiting. His temp was 37.6, heart rate 120, respiratory rate 24, blood pressure 70/40. In general, he was bent over in pain and ill-appearing, could barely walk or barely move. Abdomen had direct and indirect guarding, diffuse tenderness to palpation, worse in the right lower quadrant with rebound, and no organomegaly masses. The rest of his exam was unremarkable. So what's your differential diagnosis? Appendicitis? Okay. Ruptured appendicitis? Okay. What else?
Septic shock.
Septic shock? Bowel obstruction? We can do better. What else is on your, what would cause a bowel obstruction? Worms? Okay. So he has an acute abdomen, do we all agree? Which could be probably peritonitis, appendicitis, ruptured appendicitis, or an obstruction maybe from a worm bolus. He could also have volvulus or intussusception. So I put this case in to point out that WHO, as we have heard already today, has resources for surgeons with the disclaimer that I am not a surgeon. But the main resource is the surgical safety checklist. They have lots of other resources, but the one that we should all be aware of is that WHO has a surgical safety checklist that is in use all around the world and has been adapted for settings all around the world. So Elmer went to surgery, and another disclaimer, I have not been paid by Pepsi or Coke. This is what the surgeons found. Actually, they found a whole ball of worms in his gut and saved one in a Pepsi bottle for us all to see. Again, soil-transmitted helminths or intestinal worms are another neglected tropical disease. Intestinal worms affect 20% of the population of the world. 1/5 of the population of the world currently is infected by intestinal worms, and they're usually roundworms, whipworms, or hookworms. Eggs are passed in the stool of infected people and contaminate food, water, and soil, which is how they're passed. Hookworms are actually passed if you walk barefoot on infected soil and they bite your feet. So the morbidity is because it feeds on the host tissue and blood and causes iron and protein loss. These worms can cause malabsorption, diarrhea, loss of appetite, impaired growth and physical development, and intestinal obstruction. Would actually be a rare complication, but is there. A rare complication is perforation from that obstruction. You can also get prolapse. And the morbidity is directly related to the worm burden. So the more worms you have, the more chance you have for all of these complications and morbidity issues. Your treatment is your anti-helminths or deworming medications, surgery if needed, and treating the complications. So these are two resources that list out your doses and FDA approvals and indications for pregnancy and childhood that we should all be aware of within the United States. In the majority world, we have the WHO guidelines to follow. But because we're giving this conference in the United States, I want us to be aware of the United States. So the story is not over yet. This is Elmer with his family. About 7 to 10 days after his surgery, he's ready to go home, looking much better. So his instructions from the surgical team that was visiting the hospital were clean the surgical site twice daily with soap and water. So I got to actually go with the missionary who was driving Elmer home. I was a visiting family doctor, and this was our road to his house. We drove on this for 3 hours. This is the road that he rode on in the back of a picnic with an acute abdomen for 3 hours. We eventually got to a point where we could no longer drive and had to walk up to his house. This is his house. This is their backyard with their chickens and mule. This is their kitchen. This is behind their house, the fields where he was up tending the cows. It's a little hard to see, but there's a blue water tank in the middle there that is the water storage for his community. And this is the water pipe in front of his house where the family is getting their water. So what's wrong with this picture? What do you think about the instructions? Clean the surgical site twice daily with soap and water. He's going to get infected, right? And he's probably going to get more worms if they continue using the same water that caused the problem to begin with. So we need to contextualize and think through all of these different situations. WHO has a strategy for control of soil-transmitted helminths, which is periodic treatment, which we talked about with the IMCI, of people at increased risk, which are children, women of childbearing age in the second and third trimester, and women pregnant in the second and third trimester and breastfeeding. And then health and hygiene education to prevent transmission and reinfection or other complications from surgery, getting the surgical site infected, adequate sanitation to reduce soil contamination. So our job is not over. Again, we go back to Terry and community health, and our job as healthcare professionals is not over after the surgery is done. Again, IMCI has the vitamin A and the routine worm treatment. So we're done with Elmer's case. These are a couple other WHO resources that I've mentioned, integrated management of pregnancy and childbirth, and there's which is the green booklet, and then the yellow booklet is Managing Complications in Pregnancy and Childbirth, which is needing a higher level of care. Again, to remind us, we're not quite done with the worm case, giving bendazole to women in their second and third trimesters as prophylaxis or periodic treatment, and then to breastfeeding women. So we've seen that WHO has guidelines and recommendations for children, community children, hospitalized children, malnutrition, surgery, specific diseases, pregnancy, which is not a disease, but we have to contextualize them for the situation that we're in. And we have to know that Elmer's going home to that, and that Ermias has 6 siblings that could all now be infected with measles, right? Which we do in the United States, but it takes a little bit more mental exercise if we are not used to living and working in these other areas.